the first thing, obviously, I always get all my guests to do is just to tell me about their background and tell those viewers about your background and where they can find you, stuff like that, just kind of your journey to where you're at the moment.
Yeah, well, thanks again for having me. I am an orthopedic physical therapist. I've been practicing for 17 years, which seems kind of crazy because it feels like I was in school not that long ago, but I'm getting old. But yeah, I've been in orthopedic physical therapy for 17 years. Prior to that, I grew up as an athlete. I was in martial arts and gymnastics, so was exposed to physical therapy. Like a lot of people who actually go into this, I had surgery in high school, had knee surgery, and went through rehab, and so that was sort of my first exposure to physical therapy. Really, before that, I was super interested in exercise, but more from a performance standpoint. And I studied exercise science. That was my undergraduate degree at university, was in exercise science. So, and I was a trainer for a while I was in college, doing personal training, and but then ended up went the physical therapy route for three. It's in the U.S. It's a 3-year program after your undergraduate degree, and it's been kind of an interesting journey. I haven't had sort of the typical physical therapist journey. I only really practiced in a traditional healthcare-based clinic for 2 years, and then really, it's a hard system. I don't know what it's like where you're at, but in the U.S., it's just there's a lot of problems with our healthcare, and it's as a PT, their reimbursement's not great from insurance companies. And so clinic owners, because of that, they have you see a lot of people each day. So I was seeing 15 people a day, and you just don't feel like you can really give high quality service and care. And so that a lot of PTs unfortunately burn out. I think in the US, the average time that someone stays in the profession is only 9 years. But you go to school all this time, 7 years of school, and then to only stay in it for 9 years. So I knew I had to make a change. It was kind of burning me out. I wasn't really enjoying seeing patients. I always liked the education part of it, kind of teaching people about their bodies and why they were doing things, how pain worked, all those things. And so I then transitioned over to teaching in a kinesiology department for 8 years and really loved that. I was able to impact more people and just got into education. As you'll probably find out, you'll have to make me shut up. I can talk a lot about this stuff. I don't actually like people always laugh. I don't really like doing physical therapy. I just like talking about it. So education is really a spot for me. And that slowly by accident, I mean, not by accident, but I kind of just got on social media as a hobby. Like I just wanted to put out helpful stuff to people. That was back at the end of 2016. And really all my social media stuff I would have never thought it would grow like it has. I never would have thought it would be something I could turn into a business. It was literally just a hobby. I had no idea. There was no strategy. I can't take any credit for it. But these accounts, it's mainly Instagram and YouTube, but at RehabScience. And yeah, like you said, the Instagram has been amazing. It hit 1 million followers in May, which was the same month my book came out. So it was kind of a cool journey to have those two come together. And YouTube just grew. YouTube just is just over 500,000 now. It grew 100,000 last month. So it's been amazing. I'm super grateful for it. I've always wanted to have a platform where I could educate people and impact large groups of people. So I'm really grateful for where it's at.
So, what inspired you to start RehabScience, and kind of how does it differ from like the other resources that are out there?
At the time when I started it, I'd been a physical therapist for 10 years at that point. And one of the big motivators was frustrations around narratives patients would come in and tell me, so they would, whether it was from a family member or the internet, or sometimes from other practitioners, it was just people often, we all carry beliefs with us, right? And a lot of patients will have these beliefs that are actually quite harmful. And, if we look at the research on it, people have a harder time recovering sometimes when they're harboring these sort of negative beliefs. It's actually the opposite of placebo. It's a nocebo. So people will receive these nocivic messages it's so annoying when it comes from other healthcare practitioners. And sometimes that's done unintentionally. Sometimes doctors say things to people that are just the language they use is harmful. And look, I've been guilty of it in the past too, I'm sure. Like there have been times I've said things that sometimes words you don't think are harmful to people. And there's been a lot more research on this, even just saying something like wear and tear or chronic, or there's been a lot of research on this, that those words can negatively affect people, how they feel about their bodies, how they respond to pain, and ultimately how much they recover. So a lot of the motivation in the beginning, what really frustrated me was when practitioners would say things to people basically to keep them coming back for care, to keep them dependent, sort of like fear mongering type of narratives. And that stuff was super frustrating. I also just knew that exercise had great evidence for most musculoskeletal conditions will get better with time and the right movement. And I knew that was stuff I could show on a platform. I could do like a rotator cuff post and show 4 or 5 rotator cuff exercises. And there are things that people could be in places in the world where maybe they don't have access to good care, but they have a device and they could learn about a condition and do exercises and get better. So those were kind of the 2 main motivations.
Do you feel like, just off on a tangent slightly, but like because some things are money based and there's like an incentive around money, people want to get paid, that sometimes there's not necessarily a strong, like people don't want to help others recover fully because obviously there's that incentive of like, I still want to get paid, I still need to get paid. Do you know what I mean? Like, I think sometimes when money's involved, like that can become a hindrance for someone actually progressing and getting better in movement or any type of thing, because people essentially want to get paid, right?
Oh, for sure. It happens a ton. I mean, there are unfortunately a lot of rehab sort of, I will say, like pain-based practitioners that, yeah, it's good for business to keep people dependent on what you do. So unfortunately, I think actually if you were to actually just teach people, help them get better, and then teach them how to self-manage, I think you'd still have business because they'll tell their friends about how good you were and how fast you got them better, and then other people will come in. So I think it's really pretty short-sighted in terms of those practitioners, just convincing people. And it's usually hands-on based care. It's like where it's massage based or manipulation, like adjustment manipulation based. It could be things like acupuncture. There are all these things that we lump into passive care, like where somebody's doing something to you. Those things are easy to create dependency with because the patient can't do it to themselves. But really, when you look at, a lot of those interventions do have some evidence for sort of short-term changes, positive improvements in pain. But the thing that has the long-term evidence is movement and exercise, which really any good rehab practitioner should be teaching patients how to self-manage, just like if you went to see a psychologist or a counselor. I mean, they're teaching you strategies to cope with your symptoms. And so in the research, they'll talk about self-efficacy, like basically the person feeling as though they can self-manage. And that's supposed to be a big part of rehabilitation, is boosting self-efficacy in people rather than, hey, you've got to come back every week or your back's going to go back out of alignment, or, that stuff was super frustrating. I mean, you hear that a lot, where people believe they need that practitioner to put them back straight or put them back in alignment, or, and they just feel like there's a certain amount of anxiety around that what if they lose that person or they can't see them, so that stuff, it's so frustrating to me.
How do you like, because obviously the fields are like ever, the field that you're working in is kind of always changing, always growing. There's new knowledge out every sort of, probably every day coming out. How do you kind of keep up to date with sort of the latest things and whether they actually work or not as well? Because sometimes something new can come out, but because it's new, it's not necessarily tried and tested. So how do you like kind of work out what's good and what's not, and keep up to date with that?
It is tough. I mean, like you said, there's a lot of, you can kind of drown in research, there's just research coming out all the time. And so I do think that there are a couple of different strategies I implement. I think one of the positives of social media is that I tend to follow people who, my account, I just follow people who are kind of in a similar industry, rehab and fitness, and who are interested in kind of the research and evidence. And there are some people who are better about it, of course, than others, but you do learn a lot. I do think that is one of the values of social media, seeing other people post about current research and discuss it. There's a lot of people who are more highly trained in terms of kind of analyzing research. I'm coming at it from more of a kind of clinical perspective, but you have a lot of people online who are, PhDs in different areas, who research analysis really is their forte. And so I think I learn a lot there. There are certain journals that I just kind of know tend to be a little more rigorous in terms of the research that they publish. So, and then sometimes there are certain authors that you just know about, like I tend to be pretty interested in like tendinopathy, different tendon problems. You see a lot of people with tendinopathies. And so you'll start to recognize some of the researchers out there who are kind of leaders in tendon science. So sometimes I'll specifically look them up. Sometimes, honestly, sometimes it's just going on PubMed, and it's actually having these social media accounts has helped keep me current, because I will say I'm going to do a post on a particular topic. I will spend some time on PubMed just looking at, maybe I'll do a filter of 2017 and, have that be the oldest research, but just look, what are some studies, what are the new studies on this area, and then just kind of scan through and then just having that hierarchy of knowledge, because, right, there's a lot of different types of research. And so we look at kind of this pyramid of rigor in research, with systematic reviews and meta-analyses being at the top. And so I'll usually start by kind of looking at those. A lot of times the conclusions in those are we need more research. So sometimes, but they're good because they're studies of studies. They're taking a lot of studies and grouping them together. And then I'll look at randomized control trials. So I try to find studies that are recent on the topic I'm going to be writing about, and then are more rigorous types of studies. But I'm not perfect. I mean, I try to stay on top of it. There are people who are a lot better at it than me. Every time I go and do when I was writing the book, there's almost 500 research citations in there. I spent a month just on PubMed, going through each topic almost all day, just looking at what are the current studies, just trying to synthesize all of it. And it makes you realize, when you sit down and really do that, how much you've missed, because there's just so much out there.
So when you say about, obviously, your book, where can people find that, and kind of what was the what was your main agenda with that book? What was the main goal for you when releasing it?
The goal with it's actually pretty similar to what I do on social media, just a much more comprehensive version. So my social media, like I was saying, it's really highly educational. It's meant to teach people about common musculoskeletal conditions, common orthopedic conditions, and then what kind of generally the management of that condition, what the treatment would look like. And so the problem on social media is that it's these, you're limited on word count and how much people are going to read, and people have a hard time finding things. So, and I really can't get into much of the detail. Some of the topics that you really need and want to teach on don't get any engagement on social media because they're not sexy, So something like, and the book was just a great opportunity to put all of that information in one resource, and to cover topics that don't do well on social media, but are so important for people to learn about, like pain science. Pain, just understanding basics about how your pain system works and what pain is, kind of basic pain neuroscience, can be really helpful for people who are in pain. And so we spent 5 chapters covering, even, and a big one is factors that are involved in pain, like talking about how sleep and stress affect your pain on social media gets no likes. Nobody's going to like that, but it's so important. It's so important. I talk about it with every patient. And so it's one of those things that there are some people who have pain that is more associated with their thoughts and emotions and lack of sleep and nutrition. And if you don't talk about that stuff, they might not get fully better, So the book was just an opportunity to really talk about all of these things, these different factors and things about pain and injury. And then, probably 2/3, a little over half of the book is rehab programs with pictures of me doing all the exercises. So it is very applicable. I hope that my hope with it was it'd be kind of this coffee table book, sort of like an injury and pain encyclopedia, that if somebody had something, I'd be like, oh, I've got tennis elbow, I'm going to open up to that program and learn about it and see what I can start implementing. Because the truth is, most conditions get better just with time. And if you incorporate some movements that kind of gradually challenge the area, you can help it get better faster, and in a lot of cases reduce the risk of it returning. So you can learn all that in a book. There's a lot of things you don't need a practitioner for.
Sorry, what would be your top three tips for someone with tennis elbow, like how to sort of overcome it, and basically develop better? Because I've actually suffered with tennis elbow for a period of time, on and off. So yeah, I was just curious for my own benefit, really, on that one. I've been a little bit selfish, but
Yeah, no, dude. Yeah, it's one of those ones I'm interested in because it falls into the tendinopathy category, and a lot of people have these tendon kind of connective tissue type pains, especially as you start getting, younger people will have them too, but I think as you start getting age of 30 and on, you start seeing a lot of people come into my clinic. I'm 41 now, and I just have tendinopathies. It seems like every week I've got something that's flared up, but yeah, when you look at something like tennis elbow, it involves your wrist extensors, which attach up at your elbow. So they're on that top side of the forearm. So you're actually doing wrist exercises, but they help the elbow. And so I would really say probably the top pieces of advice I'd give people who have that issue is, one, behavior modification. Behavior modification is huge for almost anything in rehab. And that basically just means try to identify the things in your life that are triggering it and work on modifying those. Or in some cases, we try not to eliminate things for people, but sometimes you might have to temporarily eliminate something. Because it can be, even if you're doing the right rehab exercises, sometimes things just won't get better if you just keep stirring them up. So, for something like a tennis elbow, a lot of times people, it doesn't always involve a racket sport. Actually, probably most cases that come to me aren't tennis, but you can, like if you had someone who was a tennis player, I've seen tennis players who they switch to a new racket. Maybe it's a little bit heavier, or they change their swing a little bit, and those things can get it going. Sometimes it's just they're doing more, maybe it's something they've been doing, but they increase the volume. A lot of tendon issues are like that, where it's just we talk about it as like load management, managing the load on the tissue. And so for a lot of people, it's that they've increased the volume, of whatever exercise or activity they're doing. But like I say, a lot of people who have it are not athletes. They might have done a lot of gripping. Like you hear a lot of weightlifters who, when they're doing heavy gripping, or maybe they increase the number of pull-ups they're doing or something, and just that isometric kind of grip. So it is a little counterintuitive, because actually a lot of times when it comes to strength training, the exercises that trigger the tendon are actually really similar to what you would do in terms of the treatment. So that's probably the second piece of advice, is that when you look at any tendinopathy, and tennis elbow fits into this, the thing that really has the best evidence is gradual loading of the tendon. And so it's this really specific, it's basically really specific strengthening. And when you look at the research on these, people kind of work through this progression where they'll go from isometrics to eccentrics to full range contractions. And so one thing that can be really helpful when people have tennis elbows really flared up is just to basically take a dumbbell, and you've probably seen this, where you hang your wrist off the edge of a table or something like that, at kind of a heavier dumbbell, and you just hold it and just do an iso. You're not moving, but the wrist extensor muscles are contracting. And I think what we're seeing in the research over time is that you actually, for tendons to get better, you have to load them more than you might think a lot of times people want to pick up a really light weight and do things like that. And with tendons, they actually seem to respond better with heavier loads. And so that's probably the other big piece of advice I'd tell people is, there's lots of resources out there. I have them on my page. In the book, there's a tennis elbow program, but finding these wrist extensor exercises and starting to specifically strengthen that tendon, those types of exercises usually work best in terms of desensitizing the area, and then building the capacity of it so you're less likely to have it when you return to whatever activity initially triggered it.
Yeah, because I saw just recently you posted about the use of the mobile phone as well, and how that can have like an effect on your tendons and stuff like that. And I was looking at it thinking, can it really? And I don't know. Like, obviously, is technology having that effect on the body to an extent, even with where we're looking down on that? And also, I'll throw in there as well, just around that, is like, how is technology sort of helping with diagnosing people with issues and helping prevent issues as well?
Yeah, that one today, it's called de Quervain's tenosynovitis. It's basically an inflammation of the sheath on some of the thumb tendons. And, texting and gaming are talked about with that sometimes. I think it's probably actually less of the cases because it's pretty low load, right? Like, even though you might be doing it high volume texting and things, but the stress on the tendons is so low, you're only lifting your thumb weight. Most of the people who actually have these problems usually have higher forces on their tissues. So actually what you hear a lot, every time I do that post, I have parents speak up and say, oh, especially a lot of times it's moms saying, I actually got this when I had a new baby and I was carrying the baby all the time. And so that kind of position of kind of using the thumb and wrist to deviate and kind of hold the kid, you hear a lot of parents will get triggered there. The other one is people will talk about higher force kind of squeezing, like maybe gardening or things like that, where they're using a tool and they're putting more force on those tissues and then doing it repetitively, maybe for hours out there. I think you hear more of those situations, and that's pretty typical for most tendons. They tend to get triggered by things that are, you're doing lots of repetitions of them, and there's some force on the system, whether it's you're kind of squeezing the muscle or maybe it's a runner and they're not squeezing their calf really hard, but they're doing lots of repetitions of contractions, and that gets the Achilles tendon going, things like that.
It's not a bad little. I don't know. Like, obviously, like you said, I was just thinking there might be a proper issue because of the phone, but when you explain it in that sense, that there isn't actually really any pressure to cause an issue, that does make does make sense. Especially even when you said about the tennis elbow as well. Like, obviously, for me, like, I got it with bench pressing quite a lot, and jiu-jitsu. Obviously, getting armbar doesn't help. So thanks to everyone that gets me in arm bars. But yeah, it's just it's one of those, like, where I suppose, like you said, it's kind of thinking about training those wrists and doing that little wrist exercise and building up and stuff like that. But yeah, just to touch on again, like, has there been any technology that's come into your field that's helped you sort of analyze people's issues better and help them recover quicker?
Yeah, I mean, there is, there's a lot of cool technology out there actually in terms of just studying human movement and analyzing it. I actually, for a period of time, I didn't mention this before, but for about 3 years, co-owned a biomechanics lab here in the town I live in. And that was kind of the idea. I opened it with another physical therapist here in town, and we went down and studied with a professor down at USC at University of Southern California, who's a biomechanics researcher, especially focused in kind of the low back down. And so, we opened this clinic and brought in all this technology. So, things like high-speed motion capture, where you could put all the little, right, like the little markers on people's joints. We had these cool ones that were LED, and you had a little remote, and you light them up either green, red, or blue in a particular pattern, and the cameras would detect that. And, we had a force plate. So we had this unit in the ground that could measure how much force in newtons you were putting on the plate. We had a treadmill that was force plate instrumented. So when people would run, it would tell how much force they were putting into each step, how much force they were putting on each part of their foot. It gave that. And then we had EMG. So you could put these EMG sensors on, and that would measure how much muscle activity, how active a muscle was during certain movements. And, that technology was useful in some cases, because there are things that are just really hard to see with your eyes. Human movement, even walking, you don't think of it as being fast, but when you're actually standing to the side of someone and trying to look at each joint, it's really hard to know, oh, is the hip going through 20 degrees or is it going through 10 degrees? You're just trying to eyeball things. There's a lot of error in that. And so there was sometimes the motion capture was having that video and being able to see movement could be pretty useful. The EMG was actually pretty nice because it was actually really nice in terms of exercise prescriptions. Like say you wanted to give somebody an exercise for their glutes, you could put the EMG on and have them complete different movements. And it was interesting to see, you'd have one person where they'd do a squat or something, you'd see lots of glute activity, and another person, you'd see hardly any glute activity. And so it was interesting to kind of figure out for each person individually, maybe this exercise is better for them because they tend to turn this muscle on more. They have a better connection to it than this other person. Maybe this exercise works for them. So but I actually don't use any of that technology really anymore. As interesting as it was, I don't think it changed a lot of what I do. And so I don't incorporate a lot of technology anymore. I'll say, there is one piece of technology that I don't currently have, but is the one thing I would consider getting these days, which is a handheld dynamometer, which is a way of basically measuring how much force people can produce, how much strength they have. So you hold it, and in physical therapy, we do a lot of this manual muscle testing where you tell someone to hold a particular position, and the idea is you're testing their strength, and you give it a rating on a 1 to 5. But it's so subjective, right? It's my arm strength. Again, I'm just picking a number. I mean, so a dynamometer, you hold it in your hand, and so if I'm testing somebody's hip, I could push down their leg, and the dynamometer would tell me the maximum force that they generated during that contraction. And so there are tools like that are actually quite useful, but I hardly use any technology anymore. And that's coming from a spot where I was using almost every piece of, I just don't think, it's probably the clientele. Like if I was working with a lot of individuals, like say I was working with a lot of athletes who had had ACL tears, then the technology becomes more useful, especially the dynamometers, because you want to know, what is their hamstring to quad ratio in terms of strength. There's research looking at that as a predictor of re-injury. You might want to look at how do they land from a jump on the force plate. Can you teach them how to land more softly and with a different pattern, maybe a hip dominant pattern versus a knee dominant pattern? I just don't see as many of those people anymore. So I'm really seeing kind of people with just general pain issues who are coming in with back pain and things like that. I'm not doing so many like return to sport assessments. And that's where the technology I think can be really useful in those younger athletic populations.
What would you say is like the number one sort of reason that you've seen for why like people struggle to activate and stimulate their glutes?
Yeah, it's an interesting thing. There's a lot of talk about this online because you see posts about, how to activate your glutes, and really, I think I care less about it than I used to, because everyone activates their glutes as long as they don't have paralysis to that muscle, right? Like it just, I don't know if you've seen these types of things, but like if you look at actually the research, kind of really evidence-based people in this world, they will usually say, stop worrying about it. Like, don't worry about, because actually EMG, as useful as it can be in some ways, it isn't always a good predictor of what is the best exercise to get someone stronger. So I think sometimes humans, we just have a lot of variability in our nervous systems and how we activate things and what that kind of muscular coordination looks like. I think that's what's interesting about humans. We all kind of move a little differently and we activate things a little differently. There are kind of common trends, like if you look at walking, for instance, there's been a lot of EMG research on walking, and most of us turn our muscles on in a certain order as we move through the gait cycle, certain muscle groups at a certain time. But people still have variability, and I think that's true in exercises as well. I did like the EMG for, I think when you can find an exercise where the EMG the signal would be higher, people would tend to feel that muscle a little bit better, like they could feel it working. And so I did think that was sometimes useful for kind of building that mind-muscle connection and then trying to get that to cross over maybe to other movements. But I definitely, I think I worry less about it now than I used to. Pretty much all of us, it's not like anyone who's healthy, they shouldn't be worried about are their glutes being activated or not. Like your glutes are going to turn on if you get up from a chair or do a squat. Your glutes are going to turn on in that. Like I say, the only time there's going to be situations is if somebody has, like a nerve paralysis or something like that. So I don't know if that answers that question. I worry about it less than I used to.
Yeah. No,
Yeah,
no, that's fine.
yeah, it doesn't really, honestly, I think the reason is that in rehab, really the things that are guiding you are the person's symptoms and their function, not how well they can turn on a particular muscle. It's more like if you look at that, okay, here's an example with the glutes. So glutes, when we were talking about tendinopathies before, there are a lot of people who get gluteal tendinopathy, where they get tendon pain associated with their glute tendons, especially gluteus medius and gluteus minimus, where they attach on the outside of the hip. So people will feel pain on the outside of their hip. And, when you're working with someone, I don't so much care about, okay, let's put some EMG on and find out what glute exercise is going to be the best for targeting this. I actually care more about what glute exercises reproduce the person's familiar symptoms, because that I think is more indicative of what exercise is actually going to challenge the area and help them get better. So if they do maybe they do a sideline hip abduction, and that one actually really recreates some of that familiar symptom in their tendon, I would much rather use that symptom as the thing that guides me forward and chooses the appropriate exercise for them versus like what the EMG is telling me. That makes sense. So, I mean, I think that's why I've gone away from technology a little bit, is that sometimes we overcomplicate things. It's easy to overcomplicate things in rehab. And really, if you just keep it simple and you pay attention to the person's symptoms and their function, is their function improving over time? That's what really matters. And you don't really need a lot of technology for that.
What advice would you give to someone that's sort of starting in your field and wanting to progress, and obviously even just build? I know you said like your social media, you didn't really focus on it; it's just a bit of fun, but just to gain that knowledge and build that platform, like what sort of advice would you give them?
I think, probably the major thing is continuing education. That was all this stuff that I've done at this point has its roots in good courses that I took, especially when I was, earlier on in my career. I mean, just things like my first year or two out, I did a year-long residency in manual therapy, and I still use a lot of manual therapy to this day. But that course was huge in terms of how it propelled me forward. If I had just come out of school, because everyone kind of comes out of physio school as sort of a generalist, and that course really boosted, kind of jumped me forward in terms of those manual therapy skills. And then, after that, I went and did a 6-month course down with that professor, the biomechanics professor. And that kind of I think all these things stack together, and they help you just kind of see outside yourself, because all of us have biases. And if you're just seeing patients, you'll learn a lot of good patterns. As you put the time in and see patients, you learn patterns about humans. But sometimes that anecdotal kind of experience with patients, it could maybe lead you astray. And so while the hours and time that's put in just with seeing patients is really helpful, I think it's also really helpful to have some of these good courses from people in your industry that you respect, who can help you grow and kind of see outside yourself. I mean, because like I said, when I started on social media, I had been practicing for 10 years. And part of what gave me confidence at that point was that I was pretty used to seeing the common patterns. Most humans have kind of the same issues. You could probably pick 20 or 30, and most humans, that's what they're going to get in terms of pain and physical problems in their musculoskeletal system. So I think the combination of just, you see people want to get started on social media who really have like no experience. They're just coming out, and it's almost like they're taking the theory from their textbooks and they're just going to try and start writing content about that. But it doesn't mean as much if you don't actually have patients in your head that fit with those things you read about in the books. So I think, it's just constant education, constant kind of good education. And then actually working with people and just getting those hours in and seeing what the common patterns are.
What would you say is your like biggest or most memorable like patient success story? Like one that kind of sticks with you and you're like, yeah, that was a massive change.
Yeah, that's a good question. In orthopedics, it's as much as I love orthopedic physical therapy, it tends to be less dramatic in that way because it's people with things that I don't want to call them minor, but they could kind of live with them. You know what I mean? Like if you have a shoulder pain, it's like, oh, it hurts when I reach in the back seat of my car or pick this thing up. It's like that's not really life changing. It's annoying and you want to get rid of it, right? But it's not. So a lot of the people in terms of actually orthopedic care over the years haven't been super memorable because they're just kind of general pain things that aren't extremely debilitating. I would actually say the people that stand out to me are actually more of the neurological cases. Like I have one guy that I've been working with for 9 years, and I go to his house twice a week, and he has multiple sclerosis. And I think the work that I've done with him, it does have a very big kind of exercise orthopedic component to it, but it's more about a neurological condition and how that he has foot drop in his right leg, partial foot drop. So he has partial paralysis of his ankle dorsiflexor. So his foot, he has a hard time picking his foot up. His knee hyperextends if he isn't really paying attention to it cognitively. He has to really focus on controlling his knee. And we, over the years, have just done lots of basically it's almost like personal training, but for someone with a disease, and so he has a great home gym, and we even have EMG. He bought an EMG unit for his house, so we often compare his right leg, which is more affected by the MS, compared to his left, and we'll look at the signal in his different muscle groups. And we have electrical stimulation at his house, so we'll use electrical stimulation with his strengthening. And he has been probably the most rewarding person, partly because I've been with him for 9 years, but also just to see how helpful the exercise, consistent exercise, has been in fighting back against that disease. And there are different types of MS. So he has a type that tends to plateau for a long period of time, and then it will kind of go down in a step and then plateau for a long period of time. But he hasn't changed. He hasn't really dropped too much in the time that I've known him. And some of that is just how the disease naturally has progressed for him. But I think some of it is also just the work he's done to not submit to that problem, because sometimes people will get that, right? It's like sometimes people will feel defeated by those types of diagnoses and just kind of give up and become sedentary and inactive. And he's been great to work with because he challenges it and he pushes back on it and he really keeps working at it. And when you have someone who has that kind of mindset, it makes the actual physio care so much fun. The worst are when you have people come in. So once in a while, I'll get people like this who come in and you start to tell them about a condition or what they have going on, and they'll say, "I don't care, just fix it." Like their mentality is, "You just fix me," which is totally not is the wrong mentality, right? The thing that, like I was saying before, exercise and movement have the best evidence. Those are things you have to actively participate in. So if you think you're just going to show up and someone's going to fix you, yeah, that might help you reduce your symptoms some, but long term, you have to participate. And so the best are when you get people who are motivated and disciplined and actually stick to the stuff that you're working on. So he's probably the most rewarding one I've had. He's 75 now, and the guy's just a go-getter. It's he has bad days. He has days that sometimes we just talk the whole time and it's more like therapy, So it's but he's probably been the one that's been the most fun for me to think back on over the years.
Do you think working with someone like that, for example, how do you think that has an imprint on you as well, and like your sort of mental well-being, for example? Just because you're working with someone that has those issues, and maybe it makes you appreciate that you don't, to an extent as well. Do you know what I mean? Like, I don't know if there's like that being a reward factor as well, to an extent.
Oh, for sure. Yeah, I think I'm way more aware of how amazing it is to have a body that's healthy and I don't have issues with my function. I think about that all the time. You know, Probably I didn't as much when I was new, like a new PT. I think I was just doing it and trying to get better. But now I'm 41 now, and I think it is true. You hit the age of like around 40, you really start to think more about kind of your own, I guess, just mortality. And, you start to see people, you start to see more serious things pop up in people, cancer and autoimmune disorders and neurological disorders. And so I think I'm definitely more aware now of, just like I say, more aware of, I guess, how many things can go wrong in the body and how amazing it is when you don't have something that's going wrong. And so just feeling grateful for that, just health, and I think probably a lot of us felt more that way during COVID. I think just seeing people, how many people that affected. And I think people really did I think it was maybe one of the positives that came out of that is people reprioritizing their health. And I think more people being interested in health. I think you see that online with different people who are kind of health focused, and just, how big of followings they have and how engaged people are with what they're eating and how much sleep they're getting, and how can I incorporate meditation and mindfulness to help with my mental health. And I think that is one of the positives. People are thinking more about their health and not just taking it for granted.
Yeah, I 100% agree. I think there's been a definite shift. There's obviously still your traditional people out there that don't really care, or they just worry about it tomorrow, and then tomorrow becomes another day and another day. But even from my perspective, just seeing a lot more people being even hyper focused on just weight training and gym training, especially a lot of the younger generation, coming through now, it's lifting weights and stuff like that, which I know can actually sometimes have a negative impact on the body, not always positive, but at the end of the day, it's probably more beneficial than not, in my opinion, anyways.
Oh, dude, I totally agree. Strength training, I talk about this all the time. Strength training has the best evidence actually for injury, kind of, if you want to call it prevention. You can never fully prevent something, but like reducing the risk of having an injury. Strength training is the thing that has the best evidence, more than flexibility training, more than balance training, all these other types of training things you could be involved in. I agree with you. I think, you look at older generations, resistance training was not so widespread and popular, right? With kind of like, you think about grandparents kind of age people. And it's, I think that, I think that some of these conditions we see in people that occur as they get older, I wouldn't be surprised if the numbers on some of them drop over time because of how many more people engage in resistance training now. I mean, you don't want to think of your body as just being a really simple mechanical thing like a car where something breaks and you fix it. We know it's more complex than that. But at the same time, your musculoskeletal system is very mechanical. It's like your tissues, you still think about them. That's why there's whole courses on biomechanics and thinking about how strong our tendons are and our muscles and our ligaments and how much force you can put on them before they fail. And if you think about it in that way, resistance training, strength training makes sense because you're using progressive overload to gradually load those tissues. And we know that bone and tendon and muscle and ligament, the discs in your spine, all of those things get stronger when you load them. And so, that's where I think resistance training can make a lot of sense when you think about it that way, because if you're making something strong or you have an exercise type that makes your tissue stronger, they're going to be less likely to fail. You're less likely to have injuries. So I agree with you. There are negatives that can come out of resistance training if somebody doesn't have proper form or whatever, they bump up their weight too quickly. But I agree. I think the positives outweigh the negatives.
I'm all out of questions for you, so I don't know if you want to add anything in or let people know where they can find your stuff, purchase your book. I'll put all the links in the description anyways, but if there is anything that I've missed or that you do want to throw in quick, you're more than welcome to.
Yeah, man, this was an awesome conversation. Lots of different questions than I normally cover, so I think it was cool. There's so much you could talk about with pain and injury and keeping healthy. And, I think probably the thing I like to mention, because sometimes people see, okay, this guy, Tom, he's a physical therapist, this thing's called RehabScience. I think the thing I always try to help people understand is that the exercises and movements that we do that are utilized a lot in rehab don't have to just be when you have pain and injury. Those are also the same types of movements that can help keep you healthy, just like you and I were talking about, especially resistance training. So a lot of the exercises we do in rehab are strength and resistance based. And right, they're starting with lower load, lower weight, but then they build up over time, just like a normal strength training program. And so I think one of the things I would encourage people, if they've been in physical therapy before, or they've left physical therapy or something, they're getting over something, to just try to make some of those exercises part of your regular routine, like maybe a couple of times a week, run through some of the, especially strength exercises that maybe helped you get better, and not to just totally get rid of them once your symptoms are gone. And I think that's what I commonly run into is people will be like, oh, these are rehab exercises. They're only for when I have this problem. But so many of them are movement patterns and things that you and I both do in the gym in our strength training sessions, right? It's just, they're usually just a little lower. They're a little less stressful when they're rehab. But as soon as you get better, you just put more weight on them. And now they're exercises that keep you healthy. So I think that's maybe one thing I would just add, that kind of piece for people. And, if people have any questions, there's a lot of, there's so much you can cover, like I say, on this type of topic. People can always, I try to respond to DMs on Instagram. So at RehabScience, people can always DM me and ask if they have any questions about, hey, I'm looking for a post or a YouTube video on this topic, or is this particular thing, is there a program for it in the book, anything like that. I'm happy to answer those questions. And the book, like you said, it's called RehabScience, so it's the same as the rest of my accounts. It's a big red book. It's on Amazon and Barnes and Noble, but it's a, like I said, it's a big kind of, people are going to get it and think, people always say this is way bigger than I thought it is. It's 500 pages. It's a textbook. Like it's a heavy book, but it's meant to be this resource you can just go to and learn how to self-manage these common problems. It covers 50 problems, so there's 30 programs in it. So anyways, I hope, people will check that out and it'll be helpful to them, but I'm always happy to answer questions. Like I say, DM on Instagram is usually the best. So thanks for having me, man.
Appreciate your time. Appreciate you coming on. I'll stop recording, have a quick chat with you off stream, and then yeah, cool. I'll put all your links below and your link to your book as well.
Yeah, perfect. Thanks, dude. Awesome.